Welcome, everyone. We're very happy to have you here today. I am Dr. Cynthia Baur, and I am the director of the Horowitz Center for Health Literacy here in our School of Public Health and your moderator for this morning. So first of all, I just need to let everyone know we are recording this session. So just that's a heads up on that. So today's webinar is called Ethical Challenges for Public Health Practice when Working for Federal Agencies. And we have a distinguished group of panelists joining us here today for this conversation. And it really is intended to be a conversation. So I had approached Dr. Lushniak, who I'll introduce in just a minute, about initiating a conversation mainly for our school, but this is open to anyone, to really help our students kind of think through some of the challenges that are facing people working in public health practice these days. So that was really the impetus for doing this. And again, this is going to be a conversation, and we welcome your comments and questions. So I do want to check with our program manager, Anna Shao. Should people be using the chat or the Q&A?
If they have questions, they can use the Q&A function, and if for general chat and feedback, they can use the chat function.
Great. Okay. So if you have questions for the panelists, please use the Q&A, and if you want to chat amongst yourselves, please use the chat function. So without further ado, let's get going with the introductions. As I said, I'm the director of our Center for Health Literacy here in the School of Public Health. I had almost 20 years of federal service in the U.S. Department of Health and Human Services and the Centers for Disease Control and Prevention. We're also joined by Rear Admiral retired Dr. Boris Lushniak, who is our dean and a professor in our School of Public Health. He had almost 30 years of federal service, including as the U.S. Deputy Surgeon General, overseeing the U.S. Public Health Service Commission Corps, and serving in a variety of emergency and crisis situations, including Ground Zero, the anthrax outbreak, Hurricane Katrina, and many more. We have Dr. Dushanka Kleinman, who is our Associate Dean for Research and a Professor in our Department of Epidemiology and Biostatistics. She had almost 30 years of service as the Deputy Director of an NIH institute, the National Institute of Dental and Craniofacial Research. She was also an Assistant Surgeon General, Rear Admiral in the U.S. Public Health Service, and she was our 15th Chief Dental Officer for the U.S. Public Health Service. And then finally, Dr. Olivia Carter-Pokras. She is a professor in our Department of Epidemiology and Biostatistics. She had 21 years of service as the Director of the Division of Policy and Data in the U.S. Department of Health and Human Services Office of Minority Health, and she also worked in CDC's National Center for Health Statistics. So welcome to all of our panelists. So I'm first going to turn it over to Dr. Lushniak to kick off the remarks and also make some linkages back to our code of ethics as public health practitioners. So Dr. Lushniak.
Great. Thank you so much, Cynthia, and great joining you, Olivia and Dushanka, on this panel. And to everyone attending here today, welcome. To those of you who are going to be viewing this later as a recorded subject matter, we hope this adds to your thought processes of careers in public health if you're in fact on the student track. If you're faculty or staff, it's the application of this to our daily lives. We term this, and congratulations to Cynthia and Olivia and Dushanka for really sort of putting together the basis of this, is in the world of public health, as I always describe it, it's a bold and noble calling to be involved in this field, right? We deal with many things in the world of public health. First of all, it's a world that's filled with many opportunities, with many challenges, with many potential great effects on society, and with potential negative effects in our society. Throughout the history of public health, we've done good, and we've occasionally have induced tragedy into our society. And so the idea of ethical challenges, not just at this unique time, right? I mean, there is a unique time right now that we're going through a syndemic. We talk about this idea of, going through a COVID-19 pandemic, in addition to the world of health equity, health disparities, violence in our world, i.e. racism and anti-racism movements. And we combine that with what is a quintessential global issue, and that is climate change. And so in the midst of this syndemic, it almost becomes much more critical for us to have these discussions of the ethical challenges that the public health practitioner may be undergoing in the midst of all these things, all these pressures on us to ultimately what? To do good. Because the essence of ethics is you trying to make decisions that end up being on the right side and not the wrong side in terms of its approach and its effect on society. Now, as already mentioned, I step into this from 27 years in uniform, wearing the uniform of the U.S. Public Health Service Commission Corps, 16 years at the Centers for Disease Control and Prevention, where I started as a young epidemic intelligence service officer in the field following orders, to ultimately spending 6 years at the Food and Drug Administration. The reason I profiled the CDC and the FDA, those are two agencies that have come under a lot of scrutiny and attack, and in which our fellow public health practitioners serving at the federal level are now experiencing incredible angst and issues. I finished up my career at the Office of the U.S. Surgeon General. Cynthia's mentioned, served for 5 years as the U.S. Deputy Surgeon General, for a year and a half as the acting U.S. Surgeon General. So I've kind of seen it all from the perspective of being a public health practitioner in the field, young and junior, to one who ultimately was a leader within that public health realm. And the ethical challenges continued throughout that whole career span. I'm going to bring up certain sort of experiences in my career span. And where I want the audience to understand that we in public health we cannot separate ourselves from the aspects of politics. And politics in its purest form, right? When we deal with policies that affect populations, we try to take the science and apply them and make recommendations, decisions, regulations, legislation for the good of society's health. We step into politics. We step into the idea of, you can't tell me what to do, right? Oh, no, that's not allowed under my human rights or my constitutional rights. But in the midst of all this, we still have to come up with decisions that we feel affect the health of the individuals. Early on in my career, and this is roughly 8 years in my career, right? I'm still at CDC, and something drastic happens. What happens at that point, and those of you who are historians of public health issues will remember this, others will look this up, but look up the Dickey Amendment, right? Dickey. And I remember I was relatively young, 8 years into my career, which lasted 27 years in uniform. And this amendment came up, and what it was a backlash. I stepped into this role of being a public health practitioner thinking, I'm just here to do good. If I have the science, if I have the research, my goal is to make sure that society is bettered by my actions. And so my ethics is do good, do no harm. And yet the Dickey Amendment came up as a political backlash to what? To the issue of guns, to the issue of political pressures from, yes, groups such as the National Rifle Association and others, to basically block further research in the realm of gun violence. Right? Did it really say that? Well, it kind of talked about the idea that research should not be conducted to promulgate gun control. But what happened in 1996 was ultimately Congress passed this amendment. It was a provision inserted as a rider into the federal government omnibus spending bill, so it was hidden in there. And it mandated this. This is a quote. None of the funds made available for injury prevention and control at the Centers for Disease Control and Prevention may be used to advocate or promote gun control. The backlash was at that point in 1996. I, as a young former EIS officer, now as a career officer, was basically put into the position of saying, I don't get this. I thought we were just here to do good. And what is it that they're telling me is that, no, don't touch this arena. And in fact, that affected gun violence research for years to come. CDC, again, ethical decisions made by leadership, right, was that, or non-ethical decisions, however you view it, was, we're not going to fight this, right? This is too big a battle to fight. right? They're going to affect the rest of our funding. We're going to give up on this. And in essence, the Dickey Amendment still to this day remains an issue. It was tempered somewhat in the last few years, but we've never really gotten into getting back into gun violence research like we should have. Now there are that was an initial blast in my face saying, well, what am I supposed to be doing? And I remember at CDC being a worker bee at that point was, how can they do this to us? And yet we looked around and no one seemed to be that concerned, right? It sort of happened. Yes, the usual organization stood up and said, you can't do this. And yet we kind of fell for it. We went into our jobs. And I think that's part of the issue I want to bring up today is that right now we're talking at several levels. If we really specify the federal worker, I have several things going on at once. One is I know for a fact that people who are now dedicated to their careers and jobs and doing the right thing at CDC and FDA, morale is quite low, right? That's a reality. And part of it is, what am I doing? Am I actually adding to the public's health when everything I do is being questioned, right? Can I get involved in politics at that level? Well, we have something called the Hatch Act, right? And this is a federal law actually passed in 1939 that limits political activities of federal employees. So yeah, I can vote, but I can't really stand up, right? I always had this dilemma as well. I am part of the executive branch. Certainly being in uniform as a commissioned officer, it even became much more so apparent that I didn't choose the commander-in-chief necessarily, right? That person was chosen by an electoral college, chosen by the voting. So at some point, every 4 years or every 8 years, I had to switch to some extent and say, okay, I work for the executive branch. I follow the politics of that person. I can't necessarily fight those politics. But what I can do is obviously still instill my ability to vote, to be able to have an opinion. I need to have that tempered because I'm an officer of the executive branch. And I need to do my job to make sure that ultimately my ethics is I'm providing all the information for decision makers to make decisions. The problem, of course, is when decision makers make wrong decisions, that's where now the angst starts. Talk a little bit about the public health code of ethics, right? And I do want our listeners here today to look this up. Simple Google search, American Public Health Association, APHA, Code of Ethics. You'll see that this Code of Ethics came out in 2002, was updated in 2019. And it really talks about the idea, the various dimensions of work in public health. And I don't have enough time to go through a full litany of what it's all about, right? But in reality, there's a section there called Guidance for Ethical Analysis, right? And it talks about several key features. Permissibility of those actions. Would the action being considered be ethically wrong, even if it were to have a good outcome? Right? Permissibility. Respect. Would the proposed action be demeaning or disrespectful to individuals and communities, even if it benefited their health? Reciprocity. Have we done what is reasonable to offset the potential harms and losses that the proposed action imposes on individuals and communities? Effectiveness. Is it reasonable to expect, based on best available evidence and past experience, that the proposed action would achieve its stated health goals? And so when we look at this, right, when we look at these aspects, right, these are decisions that take place at an individual level, but ultimately become organizational decisions, right? Ultimately, CDC has a leader. And right now, the angst, I'll be honest with you, is that there's a disconnect between leadership and their ethics, what are they doing, and the public health practitioner and their ethics. And all of you know that the worst feeling one can possibly get is when one's voice is either not being listened to or being totally misinterpreted. And so therefore, when you look at this approach, when you look at the idea that ultimately, what I want people to walk away with is, as future public health practitioners for our students, as current public health practitioners be out there in the real world, continue to do what's right. Follow the ethical code of ethics. That allows you to maintain 1, respect from the outside community. 2, respect from your peers. 3, respect from those you are serving. And it's not just about respect, it's the idea of how do you apply your job to changing the world correctly. We also have a responsibility to call out things, right, when it's not happening right. And again, in the federal world, there's whistleblower options. There's certainly resigning. There's this idea of fighting, right? Again, the Hatch Act, you have to be careful that you aren't becoming political in all this, but that remains an option. I'm going to conclude my section here with a brief story. And the brief story was, are we always going to win with data? And I'm not going to go into the specifics of this argument, but when I was the acting Surgeon General, we had a major decision to be made out of the Office of the Assistant Secretary for Health. And I remember I came in well prepared with charts, with data, with the PowerPoint slides, and we presented our case in front of a major decision maker. And the decision was, are we going with A or B? I was promulgating decision A. I showed all my slides. You know, lawyers were in the room and they actually congratulated me afterwards. Wow, that was a great case. Decision time came. A few hours later, we're all back into the room. We're going to go with decision B. And I am fuming, right, at this. And I remember I turned to the decision maker and I said, listen, I'm in the position as acting U.S. Surgeon General. People are going to ask me, how did you guys come up with this decision? What am I supposed to say? I remember she turned to me, looked me in the eye, and said, you tell them because. I'm going to finish with that story because that's a dilemma, right? In our world of science, because doesn't make it. Because is an unethical answer. Because brings in the struggle of politics and policy and all these things into our realm. We can't ignore that public health is politics. We just need to figure out great approaches to be able to be the change agents in the world. Thank you.
Thank you, Dr. Lushniak, for laying out, many different directions that we could go with this conversation. So next I'm going to ask Dr. Kleinman to offer a few remarks based on her perspective and experience.
Well, it's always hard to follow Dean Lushniak and his energy and enthusiasm and his wealth of experience. And so I also want to thank you, Cynthia, for organizing this session. And I'm glad to join all of you and Olivia as sort of a collective a bouquet of federal experiences that we've had. And I think it does take that perspective of diversity within the federal government. Most of us have been in the Department of Health and Human Services, but within the other departments, especially with the social determinants of health, there are public health service officers in most of those addressing issues that are very critical to health and well-being. And so I want to give you a little bit of background of my federal pathway and career. Is I actually came from academia, where I was an assistant professor in the School of Dentistry initially at the University of Maryland in Baltimore, and joined the Commission Corps because I wanted to pursue what was then my boarded specialty. Dental public health is a specialty of dentistry within the federal sector. And I had the opportunity then throughout my 27 years to work in several agencies. I worked initially in the precursor to the Health Resources and Services Administration, to what was then the Division of Health Manpower, now the Bureau of Health Professions. So there was obviously terminology changes over the decades, and then moved to the National Institutes of Health, where I worked both in the National Institute of Dental and Craniofacial Research, but also at the director's level, overseeing the NIH roadmap for medical research, the early days, and the precursor to the now Common Fund of NIH. As a Commission Corps officer, there's a lot of different experiences, so I had the opportunity also to work in the Office of the Surgeon General, and also as a liaison between NIH and CDC for about 3 or 4 years, looking at the overlap and the gaps and the opportunities for collaborations between those two agencies. So those kind of exchanges, and I think that Boris alluded to them, as a Commission Corps officer, you're actually in a position in an agency within a program oftentimes, but you're also working and reporting to the Surgeon General of the United States Public Health Service. And in that, you are mixing and matching across different categories of officers and different agencies throughout the government. So those things bring in several aspects of ethics, since we're speaking about that today. As a clinically trained healthcare provider, I have my code of ethics that is within the practice of dentistry. As a public health practitioner, there is that code of ethics that comes with it that Boris described. And actually, the surprising part is that the code of ethics and the principles basically didn't come to the fore until 2002. That's actually very late in the game in many ways. And then as a government employee, we have that obligation of public service. And there is a tremendous amount, as we all know, of practices to adhere and make sure that the system of the civil service, the Commission Corps, actually maintains the trust, the public trust. So within the kind of things that appear that fall into controversial issues, obviously they sit in the area of science many times. And so for the area of oral health and dentistry, fluoride comes to mind. And water fluoridation has been one of the recognized 10 major achievements of the last century. And I thank Olivia for arranging a series of papers highlighting each of those achievements and critically taking a look at the science, the politics, and the communications that need to be addressed in each of these. And when you take a look at immunizations, at tobacco, at water fluoridation, you see the same thing over and over again. Science is never ending. Science has no borders. We are going to continue to revisit, reassess, learn new things, and with each step in these wonderful tools that we say are our major achievements, there are many things we're learning on a day-to-day basis. Even within water fluoridation, we're now waiting for a few outcomes of the National Toxicology Program report, and the National Academies is reviewing some of the animal studies. But at the same time, we celebrated 75 years of community water fluoridation, the benefit to the public at large, with where for $1 investment, we get $20 benefit. But the example that I want to bring is a little bit different, and it occurred during the time I was the chief dental officer. And it, I think, exemplifies this mix of ethics that reside within us. And that happened as a case in Alaska. In the state of Alaska, in the 90s, what was recognized was that tooth decay, dental caries, was 4 times greater in children than in white, non-Hispanic children, and especially a really serious rampant form of tooth decay called early childhood caries. And given that problem, the Alaska Native Tribal Health Consortium, which was collection and oversaw the healthcare system in the many, many tribes in the state of Alaska, decided to initiate a dental therapist program. And this was under the auspices of legislation that had been in place in Alaska since the 60s. And it was, it developed what was called, and still is called, the Community Health Aid Program. These were the precursors to the extenders to address infant mortality and tuberculosis and many other critical public health issues. And under that legislation, it allowed for individuals from the various communities, high school educated individuals, to be identified and trained to provide certain services that are critical to the public health of these remote communities. And just to give you an example of all the hundreds of communities throughout Alaska, many, many months of the year, one could not enter them or reach them due to the weather. So they identified 6 or 8 different community members from different communities and sent them to New Zealand, because New Zealand had a New Zealand dental nurse program, 18-month program. They came back, and as part of the community health aid program, they were certified and set with a scope of practice back to their respective communities. Well, this caused a major ruckus within the American Dental Association. And the American Dental Association initiated a suit against these very young dental therapists who were practicing under this existing legislation, and basically said they were unlawfully practicing dentistry. And to make a long story short, that the Alaska Superior Court ultimately, denied the appeal of the American Dental Association, the Alaska Dental Society, and there was no formal further work. And now within the United States, we have 4 states that allow dental therapists. And these are individuals that can produce very basic services, but they are irreversible services, simple extractions, some restorations, and very critical to the care of individuals that cannot access what I'm calling traditional care. So this is almost like the nurse practitioner program. But just to give you a sense of what did it feel like to be the chief dental officer, to be a member as part of being the chief dental officer of the House of Delegates of the American Dental Association, which was working against this particular action in a state that had major need. And then to take a look at the legislation and to make a stand and provide the justification and the support of the community based on science. So it was a mixture of politics, of professional versus public health roles, and other things that I felt are an example that students will find themselves in. You will come into situations that will probably question your ability to do this. So some of the things that I've learned through the various kind of experiences I've had is that sometimes you have to step back and think, take some time to really assess a situation. Take a look at all the elements. Definitely the science is number one. The legislative basis and whether those ways in which the legislation was implemented are comprehensive and appropriate. And I am always reminded of when the Genome Project started, and the component of the Genome Project focused on the social, legal, and ethical aspects. And we have to consider those aspects of every situation as well. So,
okay. Thank you, Dr. Kleinman. So you already heard 2 very different perspectives on the challenges that very senior people have faced as both earlier in their careers and then as their careers advance. So now I'd like to ask Dr. Carter-Pokras to share a few thoughts with us about her experiences in the CDC, National Center for Health Statistics, and the Office of Minority Health.
Am I unmuted now?
Yes, you are.
Great, thank you. Thank you for this opportunity to talk about and reflect on our experiences as federal government employees. I started out in the federal government as a GS7, and I worked my way up to GS15, so I worked under 5 presidents. I view my federal service as one of the most rewarding portions of my career, contributing to the collection and dissemination of Latino health data, the Eliminating Disparities Goal for Healthy People, President's Initiative on Race, community-based participatory research and environmental justice research efforts, revision of the federal standards for racial data, expansion of NIH's minority asthma efforts. But at the same time, I did meet several ethical challenges along the way. Just a few examples: mandated participation in rabies vaccination trial without informed consent as a Peace Corps volunteer, not being included as a co-author in documents that I wrote, work not acknowledged by academics, pressured to not present racial data by socioeconomic status in National Health Disparities Chart Book, yelled and cursed at by the head of my office because I planned a Measures of Racism and Discrimination panel as part of a research track for a National Health Disparities Conference. I had to initiate disciplinary action for employees who had misused government credit cards or computers or emails to run businesses or for personal use, and for non-performance, navigating meals at outside meetings and small gifts, and obtaining advance permission for outside activities. Just as our dean has mentioned earlier, the good news is that federal government employees have access to a lot of resources to guide you through similar ethical challenges. Examples that he mentioned was the Hatch Act. There's a social media quick guide, for instance. There are also 14 principles of ethical conduct for federal employees. There are professional resources that can help guide you, such as the American Public Health Association's Public Health Code of Ethics, and authorship guidelines, such as those from the International Committee on Medical Journal Editors. Working in a policy office for over 10 years presented even more ethical challenges than working in the bowels of the National Center for Health Statistics, which is part of CDC. Part of this was the nature of the work. I like to explain to others that seeing policy being made is like watching sausage being made. You may enjoy the tasty result, but really not want to know what goes into it. I remember one time sitting in the room with Secretary Shalala when there was a lot of going back and forth with her communications director, who was insisting that she could only have 5 priorities for the department's response to the president's initiative on race, based on what she thought, how many things that people could recall. There's a wide range of views and approaches by policymakers, practice decision makers, and policy users for each and every public health issue. And as mentioned by Dr. Kleinman, the American College of Epidemiology's Policy Committee has developed more than 17 case studies and 2 commentaries. So I urge you to turn to those for lessons learned from translation research into policy and practice. Some of those lessons are, for instance, there's a need for us as epidemiologists to work with other researchers across disciplines, that we should be trained to engage and interact with public health advocates, practitioners, and policymakers, that we need to build transdisciplinary teams for policy progress. And especially now, it's important for us to understand all sides of the argument. For scientists who engage in policymaking, there are both rewards and risks. If you're interested in engaging in policy, it's important to understand the process. You start with identifying an issue, placing a high priority on that issue, telling a story using data, developing a strong, evolving, and long-term multidisciplinary approach, reaching consensus with stakeholders, which may be broadening and changing in terms of who's involved. Consider the political and social environments and recognize that the strategy for implementing the change is situational iterative. Wins will be few and far between, and compromise is key. I like to say that you might have 100 great ideas, but only 1 or 2 will stick on the ceiling. It may be that this is not the right time for it. I was bemused when President Obama came in, and many of the ideas that we had developed during both the Clinton and Bush administrations finally came to fruition. It's not that they were new ideas, but ideas whose time had come and perhaps there was more evidence to support it. As public health practitioners, if you work in the federal government, there are many ways you can contribute to policy: by conducting and disseminating your work, serving on expert groups, even planning or participating in congressional briefings. You can also, on your own time and money, you can contribute money to organizations that advocate for public health issues. Write letters and make phone calls on your own time and in your own name to legislators about public health issues that do not pertain to your work. You can visit action-oriented sites, read print, online sources based on original investigative journalism, and offer moral support to more vocal friends. Regarding the research concerns expressed about HHS review and requests for changes to CDC's MMWR, be aware that it is actually standard procedure for reports to go through clearance. And I want to point out that in 2003, there was a similar uproar about the changes to the text in the congressionally mandated first National Healthcare Disparities Report. At that time, Tommy Thompson, who is the Secretary of HHS, responded at a congressional briefing about these changes by saying some individuals took it upon themselves and thought they were doing the right thing. They wanted to be more positive. This is what I observed several times while working at the Office of Minority Health. Career civil servants and Commission Corps officers anticipated what they thought the current administration wanted and demanded changes. But they didn't check to see if that's what was desired. And in fact, one example I'd like to give you, is during the George W. Bush administration, I was told that we could not present racial equity data by socioeconomic status in a national health disparities report. When I pointed out that the Deputy Secretary had just testified to Congress of the importance of social determinants of health, the reply from the Commission Corps officer was that this position was not in writing. And so therefore, they were not going to allow to present data by socioeconomic status. An even stronger response, yelling and cursing, when the head of my office woke up to the fact that we were planning a session on measures of racism and discrimination for a National Minority Health Conference, a session that had been in the works for months. Last week, there was a signing of the executive order and creating Schedule F in the accepted service. My personal opinion is that this may result in more examples of career civil servants and Commission Corps officers acting in fear and anticipating what they want the administration will want. Do I mean to discourage you from a career in the U.S. federal government? Absolutely not. As you can hear from the speakers before and as well as myself, my time in the federal government was deeply rewarding. But you should make sure you learn what's expected of you. Use the government and professional resources that are available to you. Recognizing that protecting public health means engaging in a long game. Be resilient. Resilience is all about being able to bounce back and keep moving. And growth mindset is the prerequisite for resilience. Redirecting yourself onto the learner path will keep you moving forward. Adopt and practice curiosity as a means of building resilience. Ask, what's to be learned from this person, circumstance, or situation? Our natural instinct and response is to withdraw, disengage, and disconnect. In preparation for today's session, I actually reached out to a very conservative family member about the new executive order to learn his point of view. And he replied, I appreciate your interest in my point of view on this topic. It's sad that nobody wants to have well-reasoned, relatively dispassionate conversations about issues like this anymore. We need more of these conversations, not fewer. During this pandemic year, just to end, to remind you that there are things that we need to do for ourselves. Just like when we get on an airplane, they remind us in the safety briefing to make sure you put your mask on before you help others. Take good care of yourself and your loved ones. Be grateful for what you have. Eat healthy and good food every day. Be physically active every day. Promote better sleep with good sleep habits. Avoid using alcohol or tobacco as a coping strategy. Be socially responsible and follow instructions from public health experts. Continue learning and get things done. Give to others, show kindness and compassion, and enjoy the present moment, here and now. Thank you so much.
Thank you, Dr. Carter-Pokras. So I'm the cleanup hitter, and we're supposed to end by 10 till. I haven't seen any questions come into the Q&A. So I realized that in my haste to get the session started, I neglected to manage that it was important to me that the Center for Health Literacy be part of sponsoring this, because we see civic engagement and what's called critical health literacy as part of what our responsibility is to foster these kinds of conversations. And October happens to be Health Literacy Month. Even though we're on the 27th, we managed to squeak this session in before the end of the month. And I really did hope to see if this webinar kicked off a longer and broader conversation within not just our School of Public Health community, but hopefully within other colleges and schools at UMD and with our counterparts across the country. Because as you've heard, there are a lot of opportunities to do good work across the federal government. We all happen to be from the U.S. Department of Health and Human Services in terms of where our careers were, but we also interacted with other agencies. And so you can do public health work in a lot of different places besides HHS. So that's one thing I'd like to kind of put out there, is that we need good, well-trained people with an awareness of what some of these trade-offs are at the Environmental Protection Agency, at the Department of Education, at the Transportation Department, at all the, Commerce. There's many, many places in which your expertise and your passions could be deployed. The other thing I kind of wanted to bring up is maybe focus a little bit more on the motivations for a career in public service. So when I was in graduate school, I pretty much knew I didn't want to be an academic. I always wanted to work in policy. And my original goal had been to work at the Federal Communications Commission. But then I found out that there was a grand total of one social scientist at all of the FCC at the time I was thinking about trying to get a job there. And the rest of the staff were lawyers and engineers because it was considered primarily a technical matter at that time. And I ended up getting into public health for reasons that were entirely unanticipated on my part, and ended up having a career in health. But my fundamental skills were in communication. And so as a communicator, I could think about a broad range of problems. And I think in public health, that's the same. Your training in public health, I think, prepares you to think about a very wide range of problems. And those skills, that way of thinking, can be deployed in different ways. And I think your sensitivity to what some of the issues you've heard about, fairness, equity, disparities, providing access to resources, all of those things can, I think, be part of what you could bring to a federal career. I did take a look at our attendee list. I had really been hoping that a lot of students would attend this session. I saw probably as many, if not more, faculty as I did students. So I guess I would encourage our faculty to think about using this webinar and other resources that you've heard about to start conversations in your classes, to encourage your students to continue to talk about these issues, to take these issues into clubs that they belong to and explore them in other ways. So for example, in Public Health Without Borders or within FACE or other student organizations that we might have. Because as you can see, many of the situations that Dr. Lushniak and Dr. Kleinman and Carter-Pokras brought up, they're not going away, right? They might be more acute now because of COVID-19, because of the media coverage, because of the conversations going on social media, because certain members of the federal workforce, their name is in the headlines many days of the week. I mean, it's visible to us now in maybe in ways that it hasn't always been in the past. But there's, these issues have been there. They're there under every administration, and we need good, well-trained, thoughtful people joining the civil service, joining the public health service, joining these various organizations, and kind of bringing a thoughtful, ethical approach to sticky problems. And I guess the last thing I would say is, if you, take a position, whether it's at a county level, a city level, a state level, or the federal level, your opportunity to influence positively or negatively thousands, if not millions of people is enormous. And that is a huge responsibility. That is something I thought about every day when during my career, is that the issues I was working on, the recommendations that I was making had the potential to affect a lot of people. And I think that's something that can be very exciting in terms of a career opportunity, but it's also a huge weight of responsibility. And I think that that's what generates a lot of these ethical considerations that our other speakers have brought up so far. So again, I hope that in the spirit of building health literacy, building a health literate state, building a health literate country, that this conversation contributes to that. And we have about 5 or 6 minutes left. We're scheduled to end at 10 till the hour. I don't see any questions in the Q&A, so I will pose one question. Oh, maybe we do we? It says there is one that just popped up. It says, I'm trying to see the whole thing here. Can't see the whole question. It says, I'm interested in what training and or mentorship you received as you encountered ethical challenges. In my experience, this often only happens once there is a problem. So that's a really good question, is like, what kind of either training or mentoring did any of you receive in confronting some of these ethical dilemmas during your career? So Dr. Lushniak?
Unfortunately, very limited in terms of any kind of formal training on this. It's interesting how the government's kind of like every other or major organization out there, right? You check off the boxes. So we have to do Hatch Act training, probably like every year or every other year, right? We have to do our own ethical behavior training, ethics, and all that. And the idea of, the responsibilities on our shoulders. And, certainly at the FDA, we had to get into this idea of, from an ethical aspect, is making sure that my own business interests / investments were not, affected by my knowledge base. But in terms of actual sort of ethical dilemmas, I think much like this, the questioner has put out there is oftentimes we relied on the mentors. We ended up in a situation and we said, I feel really uncomfortable here. Who do I turn to? And it usually was to a trustworthy source who was more senior than you, who may have seen it all, and that was your hope. So there was very, very limited in terms of other than our own ethical behavior. A lot of it was almost as if we're watching you, so we're going to teach you what to do, but we're not watching ourselves, and we're not going to, give you an opportunity to critique what we're doing. Really strange.
So Dr. Kleinman or Dr. Carter-Pokras, do you want to add anything to that?
Yes, I think we've received extensive training in regards to managing contracts and grants. Okay, that thorough, many hours, many days, many weeks of training for that. But some of these other ethical issues, like for instance, how do you stand up to a supervisor who's yelling and cursing at you? What best to do with that? Again, I think the mentor approach is an excellent one that our dean just mentioned.
Dr. Kleinman, you had your hand up? Oh, you're on mute still, Dr. Kleinman.
Okay. Well, first of all, this has been a great discussion, and I know it's just the beginning of it, but no formal training. However, public health is a team sport. And one of the things that, whether you're in government or in other parts of public health, local, state, or nonprofit, or even private sector, the issue of these questions that come before you are so complex that you need to reach out to multiple experts to bring them together. And convening is something, and building the team and problem solving is something that is built into the training. And I think we just need to extend it to a much more important aspect of leadership and facilitation. So I would say the team sport aspect of public health comes in to save the day sometimes if one does it in a very constructive manner.
I want to pick up on what Dr. Carter-Pokras said, because I would say in my experience, the ethical issues have often been framed as one of corruption, or what Dr. Lushniak said. So we get a lot of training on how to avoid financial conflicts of interest. And for example, I've been in process of being vetted by an unnamed agency at the moment, as a, sort of in a, advisory capacity for months because of the paperwork involved that is primarily revolving around clarification. And I do not have a complex financial life. I'm very straightforward. I don't have massive investment. It's I have a very clean, transparent financial life. And it's still taken, months and months and months of back and forth and paperwork and clarification and documentation just on the simplest matters. And yet the things that you've heard about, the audience has heard about today, the things that we've all raised go far beyond any financial conflicts of interest, right? They're about decision-making processes. So one of the things that I will just refer to, when I was very involved in questions of information quality. And, if you think about it, one of the big activities the federal government does is create information for the public. It's a primary activity. And so there have been many, many battles over the years about what constitutes quality assessments of information, because particularly for regulatory agencies, how they determine what is the information they use in regulatory decisions is key. And so there was a very major change in the way that information quality assessments were being made by the federal government. That had nothing to do with financial interests. It had everything to do with what was going to be considered credible from a scientific perspective. And these were going to be decisions that were then going to be reflected in what was considered allowable information into the regulatory decision-making process. And so I think the questioner's question is a good one, because I think there's been a strong emphasis on a very narrow and specific set of ethical dilemmas. And then there's this much bigger area that we've all been talking about that has had very little formal attention in this way. So
I do also want to add here that none of this is static. This is ever changing. So the dilemmas keep changing. Certainly, and again, I'm being nonpartisan here, but the dilemmas associated with this administration in particular have been very difficult, right? That they're always difficult, right? But these have been very difficult from a public health perspective. This whole idea of the recent news of perhaps introducing a brand new schedule into the civil service world, the Schedule F, which now becomes almost a political appointee civil service paradigm, is I think again a novel idea, but one that comes with its dangers. The idea that civil servants, for example, we look at the Dr. Fauci scenario, the Rick Bright scenario from BARDA, that people may not be able to be directly fired, but certainly can be dealt with in various ways, right? And that is an uncomfortable phenomenon when people are doing their jobs but viewed as the last thing I want to introduce out there. I know we're almost out of time. Is the sense is that there is a duality in public service at the federal level, right? The class distinction is the pure political appointees versus, and it's not necessarily a battle, but it's a very different class versus the career civil servant or career officer, right? And those two categories are very, very distinct. And at times they intermesh, but boy, that's a whole nother discussion we can have.
So I want to thank, we are at the end of our time. I want to thank our panelists. I want to thank our audience members. What I would say is, if you want this conversation, meaning to our audience, if you want this conversation to continue, if you think there are other things that could be explored, other people from the school that would, be interested in being part of this conversation, please let us know. At this point, this is the only session we have scheduled, but we kind of wanted to leave it up to the audience to see if there was demand for continuing this conversation. And again, I do hope those of you who are faculty members who are listening to this find a way to use this in your courses. Use this to engage your students, maybe think about potential research topics that could be pursued as a result of this. So thank you for joining us. Thank you to all of our distinguished panelists, and I wish you a happy end of Health Literacy Month. Thank you.